Hello, my name is Gloria Lau, and I am a Pediatric Respiratory Advanced Trainee. It is my pleasure to talk to you today about how we can improve ear health in Aboriginal children. I would like to firstly acknowledge the traditional custodians of the land on where this conference is held, the Whadjuk Noongar people, and of where the project was conducted, the Yawuru people, and pay my respects to their elders, past and present. You might be asking, why is a respiratory doctor looking into ears? Our research started with chronic wet cough. Chronic wet cough can be the only symptom of a condition called protracted bacterial bronchitis, which if left untreated, can lead to irreversible, life-limiting lung disease called bronchiectasis. By identifying the barriers to and enablers for the detection and management of chronic wet cough in a primary care setting, using an Aboriginal participatory action research design and implementation science approach, a program was developed together with the local community. And this program was implemented with resounding success, tripling appropriate health seeking by the community and improving clinician management of chronic wet cough. The Aboriginal community saw this benefit and said, we want to see this benefit for other conditions. So how did we get to ears? Protracted bacterial bronchitis and otitis media are fundamentally linked. The ears and lungs are anatomically connected, and the bacterial flora of the upper airways is a key factor in the pathogenesis of chest infections. In Aboriginal children, the most common bacterial pathogen that causes protracted bacterial bronchitis and otitis media is the same, non-typable Haemophilus influenza. So we met with Dr. Jaffrey Kufuapin, the clinical lead of the Kimberley, to extend this research to otitis media. And so this research is a collaboration between respiratory and ENT. And today I'll discuss the first steps of this implementation science research. The aim in our project was to determine the barriers to and enablers for the effective diagnosis and primary care management of otitis media. We chose to do our project in the Kimberley region of WA as it has the highest proportion of Aboriginal people out of all the WA regions. We worked in partnership with the local community throughout the research process, as it is vital that the research is co-designed with Aboriginal people. We used a scientific framework called the Consolidated Framework for Implementation Research to identify all potential interviewees and stakeholders. We then conducted semi-structured individual interviews and focus group discussions using questions that we developed with qualitative research experts. Data was analysed by following a thematic analysis process, which involves identifying patterns in the data, otherwise known as codes and themes. Codes and themes were discussed and verified between the research team, including 2 qualitative research experts. Data was organised and coded using an NVivo software. On to our results. We interviewed about 60 people. There were 30 health practitioners, 31 Aboriginal family members, and a community member who was the playgroup teacher. Let's start with some of the key points raised by the health practitioners. They told us about multiple barriers. Firstly, it's difficult to examine the ears, especially children. Some health practitioners were just not as comfortable examining children as they were with adults. But even when they could examine the ear, they couldn't see the eardrum because there was wax in the ear canal. Current methods to address this was using wax softening drops, but this takes days to work and require a repeat presentation. No staff members were familiar with using equipment like the video otoscope or manometer, even though the clinic had both of these pieces of equipment. But even when they can see, there were problems experienced related to interpreting otoscopy findings, especially when the view didn't look like the textbook pictures. Staff reported that they aren't certain of diagnosis and management as they haven't had comprehensive training. And even when they do know how to manage, if they want specialist input, there is more than one ENT and audiology service in the Kimberley. This causes confusion in the referral process, a duplication of services, and the potential for some children missing out altogether. And even after referring, primary health staff don't hear back about the referral, and neither do the families if contact details have changed. So how can we fix this? Health practitioners wanted skills teaching by paediatric doctors. Additionally, there was keen interest in re-establishing Aboriginal health staff clinical skills. There was a huge desire for skill sessions on how to manage wax, especially focused on upskilling Aboriginal health workers, and also skill sessions in the use of video otoscope and timanometer. Health staff also wanted ways to increase their theoretical knowledge with structured teaching and resources. And if primary health staff came across a difficult case, they wanted more support from ENT in the form of having a Kimberley ENT on-call service. This idea has already gotten a lot of interest and support from telehealth and regional staff. Although we are focused on empowering the local staff, this was a strategy identified that would help in the long run, so that staff get feedback on difficult or complex images or cases, so they will be better positioned in the future. Primary health staff also wanted the visiting specialist roster easily visible and displayed in each clinic room. And lastly, they wanted to have specialist appointments sent to both families and the local clinic. Local staff would have the local knowledge of family locations and circumstances. They would better call families or find out outdated contact details if needed and provide transport to appointments if required. Now, let's consider things from a family perspective. The biggest barrier identified was limited health literacy regarding ear health. All carers interviewed, except those that were also health staff, reported that they had never received any education on ear health before. There was also a lack of resources that could be used to assist in delivering this education. A second barrier was that families reported that when children appeared not to be listening, it was attributed to them being a misbehaving child rather than possible hearing impairment. "He's got no ears" was a common phrase that families used in good humour to describe children that weren't following instructions. Unfortunately, families reported that they felt a sense of disempowerment to express their concerns about their child due to not feeling respected or listened to by health staff. With regards to ear infections specifically, many families reported that health staff would tell them the symptoms were due to teething. This links in with the health practitioners telling us that they are not fully confident about ear health. The overarching enabler identified was to empower families with culturally secure health information through health promotion teams, campaigns, and resources. Families suggested that the best way to increase community awareness about ear health was just to sit down and yarn with them, such as at playgroups, clinics, and sporting events. Families suggested it could be done in the form of a health campaign, such as an Ear Awareness Month. Families also wanted visual resources, posters, flip charts, and videos. Families also suggested use of a trochus shell as an analogy to help explain ear anatomy and to explain what happens if the ear gets blocked by discharge. Videos could be played in the clinic waiting room or be put on social media. Doing this properly is essential, because if families are empowered to health seek, then children can get the help they need. Study limitations include being a single site study, and so potentially findings might not be applicable to other sites, but participants discussed their experiences in the wider Kimberley and Pilbara regions. Hence, the barriers and enablers identified in our project will likely be generalizable to other locations. Additionally, the recruitment strategy may have resulted in an overrepresentation of families who engage with community services, such as playgroups and health services. This runs the risk of missing the voice of families who are more isolated. However, even in the families interviewed, significant barriers were already present and numerous strategies clearly identified, serving as the first steps in improving this process. In conclusion, otitis media in Aboriginal children is a complex problem to address. To our knowledge, this is the first time a participatory action research approach has been used to study such barriers in the Kimberley region. But together with the local community, we have identified numerous strategies on how to address it. If we equip families with the knowledge for appropriate health seeking and empower the primary health service to diagnose and treat otitis media appropriately, then we are well on our way to improving the long-term health trajectories of these children. We have had significant consumer engagement with this project, and this project represents the first phase of a larger knowledge translation study. The next steps we are undertaking are to further develop these community-driven strategies, implementing the strategies, evaluating their effectiveness, and performing an economic evaluation. Thank you.